Company report. We are on.
Great. Good morning, everyone. Welcome to the Insurance and Real Estate Committee Informational Forum on the Certificate of Need Task Force. My name is State Representative Carrie Wood. I'm the co-chair of the Insurance and Real Estate Committee. Today is Tuesday, January 17th, and we will convene the task force meeting. This task force meeting is being done virtually, so it is best to watch online rather than in the meeting room. I just want to put that out there. Thank you to the Certificate of Need Task Force, who was convened at the end of last session and began working on this about end of summer up until a week ago to put together recommendations for our Certificate of Need process. That is all for my remarks. Would anyone else like to remark? I'll even ask if Senator Matt Lesser is on, who was chair when this was convened. I don't see him. Senator Wong, any opening comments?
Thank you, Madam Chair. I just want to commend the working group. It seems like there was a meeting every single week, and I want to compliment them for all their earnest efforts and look forward to hearing the report. Thank you, Madam Chair.
Thank you, Senator. Hopefully by now, members of the committee, the Insurance and Real Estate Committee, have a copy of the report in front of them. This was put together for us to review. I will pass it over to the task force for the team to really take it any way you'd like to present this to the committee, and then we will open it up for questions following the presentation from the task force. Sound good? Great. I'll pass it over to the task force. You guys can take it from here.
Madam Chair, this is Dan Keenan, and I can probably kick this off from the task force perspective as for working group A. I can report out. I do have slides to share if that would be appropriate.
That would be great.
Okay, great. Thank you very much. I'm going to share my screen, and so hopefully everyone on the call can see my screen. And thank you again, Madam Chair, members of the committee. Appreciate the opportunity to report out this morning as a member of the task force and then a member of the subcommittee or working group on which is called Working Group A. And our working group.
Mr. Keenan, I'm so sorry. I don't see your screen.
Okay,
I just do a post.
Is that better?
There it is.
Okay, very good. So, sorry about that. So I'll just pick up where I left off here. So this is a report out of Working Group A. What I'm highlighting here is the overall charge that the task force was responsible for, and then the two lines 1 and 4 that are underlined were the responsibilities of Working Group A. Working Group A had 4 members: Pat Sharmel, Jean Ahn, Dr. Thomas Farquhar, and myself. We met many times over the course of the fall into the winter regarding looking at our responsibility of making recommendations regarding the institution of a price increase cap that is tied to the cost growth benchmark for consolidations, and secondly, looking at setting standards for measuring quality as a result of consolidations. So on the slides before you, I have our thoughts, and at least what we described as preliminary recommendation, understanding that this would be the work of the entire task force that would ultimately take on making recommendations. And I may have some of my colleagues on the work group with me this morning who can jump in, but I can at least make our initial recommendations known to the group regarding the institution of a price increase cap that is tied to the cost growth benchmark for consolidations. And while we appreciate the goal of the cost growth benchmark is to limit total healthcare expenditures to maintain a high quality of life in Connecticut, we do think that a cost growth benchmark maybe misapplied if it's used to annual increases in rates for approved settlements or individual transactions. We don't think that the cost growth benchmark was necessarily put in place to focus on all individual transactions. So we did want to start with that. And that we also wanted to highlight that we appreciate that this is a complicated situation, and that we think that there should be due diligence done regarding all transactions that come before the Office of Health Strategy. But just to kind of point out that at least in developing the cost growth benchmark, it was done really to try to control the overall growth of costs in the state of Connecticut, not to be looked at on an individual transaction perspective in every case. So I will ask if any of my colleagues, whether it's Pat or Jean or Thomas, are available if they wanted to make any comments regarding this recommendation.
I think you covered it. I think in terms of the specificity, many CON applications are for particular services, a new service. And as Dan pointed out, the cost growth benchmark is looking at a provider's aggregate spending in terms of their entire operation. So it really isn't meant to be applied down to the individual service line level. So just from a practical standpoint, the mechanics don't really work. I think we discussed that, the focus on trying to make services affordable and accessible. Obviously, we're very much aligned with that, but the mechanics of applying the benchmark down to the service line level, we just didn't feel would be appropriate.
Okay, great. Is that your summary for working group A?
Madam Chair, we have one other
preliminary,
one other preliminary recommendation. So the second question or issue that we took a look at was setting standards for measuring quality as a result of consolidation. Again, went through the same process with this, with several meetings over the course of the fall into the winter. And we do appreciate the goal of the committee process to maintain and improve quality. And we support expanding the process to allow the Office of Health Strategy the ability to consider quality of services, provided that such review is based on generally accepted, nationally recognized clinical best practices and guidelines. So we do have some concerns with capacity, and those have been discussed in general, but the capacity to actually develop those standards is a concern. But we definitely support the goal, and we do think that if quality is used, and that should be done with nationally recognized benchmarks, it should be done in a way that utilizes a baseline for improvement and not necessarily setting, call it kind of unilateral standards, but look to develop improvement models for that could be used for all providers, and that there should be a leveling of the playing field as well. So that all providers should be subject to the same rules. So those are our recommendations. I know Pat may have some thoughts on this as well, to just add some addition.
I'm sorry. First, Madam Chair, do you know, will we get these handouts also?
Yes, it was emailed to you, Tammy. I will make sure that Justin gets that over to you right now.
Okay, thank you. I'm sorry, my email is a little backed up. If it's there, Justin, if you just want to send me a note with the date, I can find it myself. Thank you.
Patrick, did you have anything to add?
No, I think Dan covered it. I think we all acknowledge in our discussions that there are established quality measures and standards for most services, and that OHS doesn't need to be in the position of developing its own. And so we're, if it's an established, accepted national standard, if it's evidence-based, I think we're, and I think the provider community has and would embrace that. Jean, I don't know that, did I cover kind of the sentiment of our work group on that?
Yes, you covered it. And I think the only last bullet in terms of color commentary that's a common theme throughout many of these work groups is the fact that there are many more healthcare providers beyond just hospital health systems. And so in order to make sure that we are providing a comprehensive plan and making sure that we're taking a look at total healthcare expenditures, they need to be included in terms of the discussions that we're having because they do impact healthcare and health quality and cost significantly.
Okay, great. Let's open it up to questions for working group A. I will jump in. I actually thought that this was really, exciting stuff that you guys put in here to establish a baseline using the clinical best practices guidelines. Does OHS do any of this now in terms of measuring quality when it comes to CON, or would this be a new, endeavor as part of this process?
Good morning, Representative Wood and council members. I actually will defer that to Laura Manzione, our new health system planning manager. However, I can tell you that during the pandemic, the staff focused on working on quality measures and incorporating quality measures in our certificate of need applications. We did quite a bit of research looking at other states' quality measures, as well as our own data that we collected OHS. But I'll have Laura give you some more detail.
Thanks, Kim. Good morning, everyone. So yes, Kim is 100% correct. We did last fall incorporate some new standards for quality measures into the initial CON applications based on what Kim just said. I don't have in front of me these specific things that we just relied on for that. Steve Lazarus, if you're on the line, I know you are. Were there anything specific that we relied on that you wanted to add?
Sure. This is Steve Lazarus. So yes, we did incorporate a bunch of quality measures. These are also measures that we are able to measure in-house. We want to make sure we only ask for data that was verifiable. So we're also working with our quality council that OHS has, that's working on developing quality standards, but based on national guidelines and stuff. But that council is still working, and I believe they're going to put something forward. I believe Olga Arma is here. She may be able to provide more details on that piece. But yes, quality measures are certainly being taken into account, and we're improving them probably every 6 months. And they are generally based on national standards.
Okay, great, Steve, because that's what the recommendation was. It was really to use the clinical best practices and guidelines. So it sounds like you're already on track to doing something like that. My next question, and then I'll move on to another person. I see we have a lot of hands up. Would there be any constraints on smaller practices, smaller providers, if this was kind of a universal new policy? Are there people that would push back on this if if everyone is now subject to the same rules? I mean, it obviously sounds great, but I'm just trying to think: would we receive any pushback? Would we have any issue with some of the smaller groups with this?
Oops.
Representative Wood, the quality measures currently are hospital specific. So I do think that, when you look at readmissions and so forth, I do think it'd be an issue for smaller providers. I do think we'd have to look at them specifically and separately.
Thank you very much. Representative Denning.
Good morning. Good morning. I'm sorry. I have a question for you. If you can show the last slide one more time, please. Level the playing field. This is the question. It kind of was, I think, the question that was asked before. To limit growth, the provider should be subject to the same rules. And I guess I'm looking for the specifics on that, such as if somebody can do it in an office-based setting, meeting the same safety criteria, but maybe not having immediate admission to a hospital or something that was, again, the playing field. Who decides the playing field?
Representative, I'll let Jean make some comments. I know that during our meetings that she had quite a bit of kind of thoughts on this issue.
Yeah, so one of the other groups that I sit on is the OHS Physician Practice Work Group. And in that work group, we've discussed quite a bit that there are a number of entities coming into or are part of the state of Connecticut, including a lot of payer providers such as United Healthcare, ProHealth, Optum now, and then private equity coming into the market. And so again, to the degree that we need to take a look at healthcare writ large in terms of both expenditures, quality, value, and care overall, they are largely excluded from any type of scrutiny in terms of any of those factors. And so if we're going to make sure that healthcare is safer and less expensive in terms of a high value health system, we've got to make sure that we're taking a look at those entities as well. And currently there is no scrutiny over those entities as far as we can see.
And Madam Chair, if I may have a follow-up question. Again, going back to who's going to set the playing field? Who determines that?
So that I don't think that we've answered conclusively, other than just to say that to just limit scrutiny to hospital health systems does not suffice in terms of a comprehensive health plan for the state, as well as control of expenditure. So I think that's still an open question. I think we're raising the fact that there are a number of large entities and increasingly more intrusive into the state of Connecticut that just are avoiding any type of oversight and scrutiny altogether.
Thank you.
Any other questions? I saw another hand raised. Okay. Great. So we will move on to Working Group C. Working Group C, do you have a presentation?
Sure. I'm Nancy Heaton with the Foundation for Community Health. And I guess I can share my screen here. Let's see. Can you see the screen?
Yes, we can see it.
Okay, so Working Group C had a number, these are our members, and had a number of questions, and I'll go through each one of these. I do have to say that was a challenging process for us. We tried our hardest and met, as frequently as possible, but they're really big topics in a short period of time. So we weren't always able to come to consensus, but I'll point out where I think we have some and where there are still some divergence. And so for our first question, enacting higher penalties for noncompliance and increasing the need for staff at OHS for enforcement, that was very simple. The second part of it, that was very simple. And we are recommending that OHS receive the additional resources that they need in order to adequately staff their roles in enforcement and compliance. So that we agreed on, and that is it's at the bottom of the screen, but that was an easy one for us to work together on. We also had, we had some discussion on the effectiveness of fines as a deterrent or a compliance tool. And we were interested in looking to see if there are other approaches. We didn't really feel like we had the time or the opportunity to see if there are other approaches to try and improve compliance or other ways of doing deterrence. So there was some consensus that fines play a role now, and they still are necessary. But there was consensus that all of the fines need more clarity. So what triggers a fine, when it begins, under what conditions, does it end? All of these questions.
Hey, how are you?
Need more
Okay.
clarity. Where there was some diversion was on, there were several that felt very strongly that an assessed fee should continue to accrue even after a fined healthcare entity has filed a CON application. So if they're still in non-compliance, even though they're in the middle of the process, that fine would continue. But there was almost equal number of people, members that thought that there was so much uncertainty, and the length of time that going through the CON process was a significant concern for how these fines would accrue over time. And there was a recognition that the timeline is also can be very long and a long process. There was also some belief that say a service was terminated without approval, that there should be a way for the entity that terminated without approval to bear some of the responsibilities and the costs of the impact of that on the community. Again, there were concerns that we're not looking at this in a different way. Could we get together and solve this in some sort of collaborative way between the community, the healthcare entity, and the state? There was a specific recommendation for a current loophole, which was created by the legislature when it appropriately put a number of days, I think, for termination. So you can, as of the last year, you can only suspend a service for 180 days, but already there's been entities that have suspended it and then started again and suspended it. So that there seems to be a need to sort of address that unintended consequence in that particular way. And lastly, on this topic, we were able to explore the Massachusetts model of handling closures. So at one point, there was a hospital that just closed its door and people walked away. And what Massachusetts did in response to that was actually create a separate pipeline for the closure of very essential services. So they've identified what the essential services were, and they have a different, more streamlined, and apparently it works a little faster to address those issues. We're not saying that that's the end all be all, but we thought that there should be an opportunity for the state to explore what works in that process, think about what are the essential services and the impact that they have, and learn more about what might make that process be have a more positive impact on everyone, the hospitals, the community, and the state. And the state itself should maintain its role in making sure that these services exist if they need to exist in a community. But hopefully there's a process that we could learn from to do that better in the future. So any questions on this slide? So there's a lot, I know. Okay, if not, I'll go to the next slide. I can't really see everybody. So this one is on the Attorney General's authority to stop activities as a result of the CON process. And we learned a lot about the current role of the AG's office, and there were 2 recommendations that came out that could slightly increase or strengthen the Attorney General's role in this process, which is, and you can read it in detail, delete the word willfully. This is very legal language, and that would help their office be better able to define when they needed to when they were able to intervene. And the second one was to enable OHS to issue and the AG's office to enforce cease and desist orders in order to halt violation of a CON regulation. And so if you can see on the second slide, there's actually drafted language that was recommended to us to improve this. I will defer to Rose if she's on here, if there's anything on here that people have questions on. And I have no idea if she's on because I can't see everybody. So.
Nancy, I'll let you know if anyone raises their hand, but no one.
Okay. Someone has their hand up. I actually do see a few people.
Have you done the full presentation? Because
No, I have one more. I have one more.
Yeah, we'll open it up to questions when
Okay,
you're
and this
done.
one's quick because we actually had consensus that about the ability of representatives in the workforce and the community to intervene, to act as interveners in the process. And we didn't find that there was any problem with the current process, that interveners have been able to, this is really left up to the hearing officers. And we all seem to have pretty good experiences where interveners who were appropriate were allowed to participate in the process to the extent that they had information or concerns that the hearing officers were interested in. So that's the end of the presentation.
Thank you, Nancy and team, for working on that. I will go to Representative Denning, and then I do have a question.
Sure.
Thank you, Madam Chair. The question I have is, who drafted the change in the statute that you have on the previous slide?
So this was someone in the Office of the Attorney General.
Okay, thank you.
I wanted, Keith, are you all done with your questions? That's it? Okay. I wanted to ask about the loophole with the suspending of service. I'm sure you know that we tried to define that last session. We did include the definition for termination of services, but your group still feels that the suspending is still going on.
Not that this is, well, that there, it's an opportunity for people to suspend, restart, and suspend. And we were informed by OHS that this is something that has happened. Otherwise, it actually wasn't something that we had thought of. So that's a concern.
I wanted to just ask OHS if they could give us an update if the termination of services definition has been helpful, or if we need to continue to explore a defining of suspension of services, or at least kind of look at the recommendations that were presented here. Do we have any feedback on that from OHS?
Representative Wood, I know Laura also has been looking at the definition because of our civil penalty current issues that we have at OHS. So I'll just let her respond to that.
Okay, thank you. Yes, so Representative Wood, we have been tracking, I'm going to say cessations of services by hospitals, because once again, this provision only applies to hospitals. So we've been tracking when we learn of cessations. We don't always get notified. We don't need to be notified when something stops. But we keep track of when a hospital stops providing, for example, labor and delivery services. We make a note in a spreadsheet, and with the idea that we're going to make sure if they keep that service stopped for 180 days, we will deem that a termination under that new statute. The change in statute was only from last session. I think it went into effect in May approximately. So we have been tracking from the summer. And so if something was stopped in June, we are only starting to get to that 6-month point. So far we haven't come across any services that have been stopped at a certain time in, say, June or July, that have extended for that 180-day period, which would automatically characterize it as a termination of services, therefore subject to a civil penalty proceeding. But we have seen that a hospital had asked or had stopped a service, ceased a service, and before the 180-day period would have completed, they reinstituted the service. So I'm not saying that that was in order to evade the possible characterization as a termination, but a hospital might reinstitute the service thinking that they can, and then for whatever reason, maybe a week, maybe a month later, then cease it again, stop it again. So that's the inadvertent, unforeseen circumstance that I think we've come across so far. You know, we have very limited data because this just started and there's only the 20 or so hospitals in the state.
Yeah, this is very new, so it'd be hard. I was going to say, can we look at the data for this? But you know, it's new, so I think it's something that we should just be mindful of, and then we'd love to have a presentation of that data in front of future committees. Because if it is a problem, I mean, the good thing is that if the service is starting up again, I would also argue that you know, defining termination of services may has caused like a change of heart, change of mind, and putting that service in place, which is what we want. But if it's a cease and start, that would be an issue and something for us to look into. But it's new, so we don't have that data yet. So thank you. Any other questions? Okay, great. Let's move on to working group D.
Okay, so I'm still on, but I really would welcome a lot of my other members of the group to participate in this one also. So in working group D, these were our members, and we had also 3 questions. And actually, I'm going to go to this. So let's see. So our first question was about this statewide plan. And we were happy to find out that actually the OHS had already been funded in the last legislature to actually conduct this healthcare facilities and services plan, and to do so with an eye on equity and underserved populations. And I'm going to go to the second slide because actually, we learned that this will include an analysis also of the impact of the many changes of the hospital ownership and compliance issues, and that there will be an opportunity in the second phase of this report for community members to participate in the study. We again, without a lot of time, and the contract with Alterum, which is the entity that's providing this, going to be conducting this survey, we weren't able to talk with them to learn more about what the methodology was, or get more clear from their point of view what the expected deliverables were. But we thought that that is something that the legislature probably should keep on top of and know what it's doing. But recognizing that the OHS process, the CON process specifically, is a reactionary one, we actually recommended, and I'll go back to the first slide, which really I think talks about this more appropriately, that OHS consider using this healthcare facility and services plan as one piece of a puzzle, and that if it could be combined, the state of Connecticut is not that large, right? So that could be, if there could be a look by OHS in its role to look at ensuring healthcare access equitably across the state, not specifically for the CON process, but across the state, to really look at all the data that comes in, whether it's from the community health needs assessment plans, or it's from things, the health professions shortages, data, which, to be honest, has been not very accurate in the recent years. Looking at vulnerable population maps, looking at the social determinants of health, looking at all of these pieces. And OHS does communicate with, other departments, that, the health department and all of the other departments, overlaying those. And so maybe we could map where there are deserts or where there are problem areas in the state that really need services. And then in its strategy role, OHS could identify those areas and work with community and the local services or other services to see what could be done, maybe innovatively, look for opportunities for funding, look either on a federal level or a philanthropy level to see if we could make sure that the needs of those particular communities are being met. So that is a more proactive role and not necessarily tied directly to the CON process, but having it was an exciting conversation, I think, that we had to think about the state being more proactive and looking to take care of the people that it's responsible for. So I sort of summarized all of that. Pat was heavily involved in writing up some of this, but Jean and the rest of you on the committee, if you wanted to speak to this as something that we talked about, I'd appreciate it. Suzanne.
Yeah, thanks, Nancy. You did a nice job of describing that. I think maybe we should say, I think the plan that's existed has been, for lack of a better term, pretty crude. It basically identified where certain services exist in the state. And what we're saying is we should look at a broader definition of health, and we're not looking at only traditional medical services, whether that's diagnostic or therapeutic service, whether it's hospital or freestanding. We're saying if we're really concerned about health status, we need to look at social services as well that impact health status. So if we can get a broad picture of the state, starting out by looking at outcomes data. So looking at the prevalence of disease or mortality, and this data is already being collected, but we haven't created a full view so that we can marry up where services are being delivered and where vulnerabilities are. So we know where the communities are that are most socially vulnerable in the state. We also know where there's a high prevalence of disease and a higher mortality. We've already done through the work of community health needs assessment, we've looked at if that mortality and disease prevalence is more predominant in vulnerable or certain racial or economic groups. And all we're saying is, let's create that view, that map or atlas, so that our planning could be more intentional if we're really serious about addressing the disparities that we know exist that became very visible during the pandemic. Because we saw communities where there were higher chronic disease burden, higher social vulnerability, there was higher mortality and poorer outcomes during the pandemic. So I think this is a moment that we have, and we're about to start a new planning process, and we're suggesting that we broaden it. And we think that the pieces are already there. It's a question of putting it all together.
And we intentionally called it an atlas rather than an inventory, because it really to represent what you learn in sort of geography class, where all the pieces of the different parts of our or of the state kind of interact.
Okay, do you have any other slides to present, or can I open it up to questions?
I have two other topics. Okay. So let's see. The second question was about guaranteed local representation of communities on hospital boards. Again, we felt that there was not a strong consensus regarding the value of a local representation necessarily on boards or the larger systems. There was really strong feelings about this. So some felt very strongly that the local hospital boards needed to reflect the diversity of the local population and be operated and organized to make sure that they provide insights not only to the local system, but up into the larger system. And there were some language that talked about percentage of coverage, and there was really no consensus on that, but there was consensus with a smaller group that there should be some representation, and that given that that the local hospitals boards or regional boards, because we found out that there are regional boards and not every hospital has its own board. There should be a process in which that's very explicit that involves members of those local boards in the larger systems planning and innovation and all of that. So on the other hand, there was a real concern that in order to really understand the very complex world that healthcare delivery is in, and particularly hospitals as very large entities, that there needs to be a lot of skill and expertise, specific skills and expertise, such as strategic planning. What are some of the trends going on currently in healthcare delivery? What are some of the best practices, and be able to understand, some of the innovation and future in order to make sure or to best position the hospitals or the health systems for long-term sustainability. Let's see, actually all members agreed to a certain extent that all the locals should participate in this process of planning for the larger system. So that was great. Let's see. And there were some members that thought giving the local board a specific role in especially community needs assessments and monitoring of the implementation plans would at least enable those local boards to be more informed, to be able to inform the larger systems about what is going on in their communities and a true picture, because not all local board members also understand all that's going on in their community. But this would be a way in order for those local community members to be able to talk more and talk more from what they know, because they have this background in understanding the community needs assessment and implementation plan. So I'll end there, and if there's anyone on our committee that would like to talk more to this, I'd appreciate it. Suzanne, did you?
Yeah, I'll jump in. Thanks, Nancy. This is Sue Lagarde. What was really important, certainly in my perspective, and I think in the majority of the committee's perspective, was to have meaningful community representation. I think we all agree that there's almost always some degree of community representation, at times, appointed by the leadership of the hospital. But we would need to figure, we're asking that thought be given to how hospitals and hospital systems appoint these people in a way that is meaningful and truly representative of the community, maybe with community input, and that it have a presence at the decision-making level, not just at a level that really doesn't have that authority to make significant decisions in terms of services, et cetera, et cetera. So that was, yeah, I'll leave it at that. Thank you.
Anyone else from the committee?
Yeah, Nancy, I'll just add that, one of the models that we looked at as comparison is the model that federally qualified health centers use, where they're required to have a certain percentage of the board, I think it's half the board, be patients of the hospital, and then be from the community also, obviously, as being patients. And sometimes that's rigged a little bit, because anybody can be a patient of the hospital. You could have a board member, you could come see a doctor once and be a patient of the health center. But it is one of the things we looked at. That was the goal of the people who felt that there should be more community representation, is that there be true community representation that had a voice. Thank you.
Anyone else?
This is Steve Lazarus from OHS. Can I just add a couple of points in general to that conversation? As far as OHS goes, and it's the facilities and services plan, I think that we were part of the discussion with the work group, and I think we were able to share that we are in the process of revamping it, and it's being done by a third party. So it's going to take about a year, and as part of the process, they're also going to have put together some advisory boards, and that's going to be made up from the industry as well, from the various parts of the industry. And I believe they're going to have 2 or 3 possibly meetings to sort of discuss all this in detail. We've already committed to sharing some of these recommendations with them as far as equity and racial and all the socioeconomic pieces we've talked about. Those will definitely be part of that plan. We also have to keep in mind, there's a shy in the ship that's also done by DPH that is more focused on the disease prevalence and that part of it. So it may not be something that can be, but we may not have that data on hand as well. But it's certainly something that we can work with DPH and share our plans and perhaps develop something as a cross agency, or at least as somebody had mentioned about the Atlas piece, and we're more than happy to sort of be part of that. As far as this facilities and services plan, that'll be, I think, comprehensive. We do look at the gaps in services, and that's just certainly one of the charges that we do focus on as well. So that will sort of will allow us the ability, and will also allow the members of this community, or actually this task force, who are from the industry, to be part and participate in that process as well. And that's certainly something we welcome. As far as the boards go, I think for the last few changes of ownership, probably certainly since 2014, we have been putting conditions in about what the boards are, what the board's role's going to be, and how the community should be interacting. We have improved at that as we've received feedback from the community as well. We've tried to make them to the point where they're now actually voting members of the board. I think we also have conditions in there where the applicants are required to hold public forums at least twice a year, for up to 5 years, and that's something we're looking at that might change as we move forward. So we're trying to bring in the community interest as much as we can, even with the independent monitors. And so we are working actively on all these pieces, but we're more than happy to incorporate any of the feedback that is brought up that we can incorporate in there.
Representative Delmicky?
Yes. Question pertaining to what you've described, the makeup of a hospital board. Are any hospitals currently in the state of Connecticut following that model that you've described here?
The model of having a percentage of local.
Right. Yep.
I don't believe so. That is the FQHCs. The federally qualified health centers are mandated by their federal contracts to do that. We believe that most hospital boards do have local representation, but I think half the committee really felt like there needed to be more a meaningful role, and that's why there's an example of using the community health needs assessments, or using some other authority on the part of local people to participate in the process of the future of the health system, the larger health system even. So, but I don't believe that anyone's using the percentage.
Are any of the hospitals even coming close to having what you've described here at all? And I ask that only from the standpoint of successes that may be already occurring that can be leveraged to as a template, as a model.
Yeah, Representative, most hospitals have specific bylaw language that typically say that board members either live or work in the community that the hospital or health system serves. So it's either the majority or all. This is a little bit different as what the community health centers are doing. They're talking about specific users of the service. And again, as representing a constituent group, meaning the patients served. These are private organizations. The board members have a fiduciary responsibility to that entity to make sure that entity meets its mission and remains viable. And I think most boards select individuals based on their capabilities to provide effective governance. So it's a little bit different type of an organizational structure than what Dr. Lagarde is describing. I think the concerns that have been expressed is the hospital being responsive to the needs of the community? And this has come and said, well, the way to do that is to change the composition of the board. There may be some other ways to hold hospitals accountable for being more responsive to the needs of their community, or to hear the voices of various groups within the community. I think Nancy just mentioned community health needs assessment. That's a process that hospitals need to go through. It's to maintain their tax exempt status. Not only identify the needs of the community, but then develop a specific plan to address those needs. And our colleagues from OHS talked about the fact that they are actually collecting those plans. And the question is, is there some oversight that needs to take place that the needs identified are being addressed? Because I think that's the real issue here. It's not so much the structure, it's our organizations fulfilling their mission and responding to the communities that they serve. And frankly, I think hospitals and health systems want to do that. I don't think they can be viable long-term if they don't do that.
Well, thank you for your comments.
Brenda, I noticed you had your hand up first.
Brenda Buckfinder.
Yes, good morning. I am aware that the citizen board or the community board in Windham Hospital was regionalized to be a mix of Bacchus Hospital and Windham Hospital. That mixes a mix of two communities, one in Windham County and one in New London County, but also one that has become a healthcare desert and one that has become an endowed hospital. So in terms of the voice for Windham, it has been sent away basically. And that even when it was in Windham, it did not vote. It did not have say in helping to keep an ICU or a maternity unit. So we're very aware, and Windham County is the most disadvantaged county in the state of Connecticut. I just wanted to put that out there. So we were very vulnerable, and we are essentially a healthcare desert. Thank you.
Thank you.
Suzanne?
Yeah, just to just tack on. I mean, it's this challenge. It's this tension between the fiduciary responsibility and the governance requirements versus having the voice of the people the hospital serves be heard. And I think it's fair to say that at least the consensus that I took away is that we all agree that the voice in many instances, maybe not all, but in many instances, the voice of the community is not being heard in a meaningful manner. Not just, and again, I run an FQHC and I wasn't the one who recommended the FQHC model, but some model whereby there's a meaningful voice as opposed to, the hospital board appointing somebody who, works for them, but is not necessarily a representative or is not somebody that the community has put forth themselves. It's a challenge to be sure, but I think it's a really important challenge that we need to try to tackle. Thank you.
Thank you, Suzanne. Representative Meskers.
Is this connection good with my earphones, just in case? Or am I muffled? Okay, perfect. What I thought was interesting between the first presentation, which dealt more with cost, and this one that seems dealing more with equity. What I'd like you both to work on in consideration as two advisory groups, or part of the advisory group, is when we're looking at equity, there's two counterpoints there. There are areas where healthcare services are oversupplied, and there are areas where healthcare services are undersupplied. So when we're looking at the process, where you talk about deserts, equity, et cetera, we should be looking at areas where on a compensation basis on insurance, on certificates of need, where we have multiple competing groups trying to go to a lucrative market that are driving up healthcare costs. And there doesn't seem to be the right structure and incentive to go to areas where there's significant need. So we're overspending on our healthcare dollars in expensive areas, if you will, underspending on our healthcare areas. And this is partially, insurance is part of that tool, right? So when you do the certificates of need, when people are allowed to recoup their costs by making the investments in certain areas, I don't have the answer per se, but I'm not sure we have the right incentive structure in the certificate of need right now to make sure that we get more equity, and also look at that competition, because in my neck of the woods, there's competition to expand services in areas that are very lucrative. I'm not sure what happens away from me. And what I'm hearing, it's not going well. So your thoughts, and when you look at the equity issue, I would like us to look at that oversupply and undersupply issue on both the areas where there's a desert and areas where you would say there's an abundance in terms of that issuing those certificates of need.
Any comments?
Yeah, I'd love to comment on that, because I thought that's very insightful when you talk about incentives in those socially vulnerable communities that we talked about in the work group D recommendations. They tend to be populations that have less commercial insurance and more government insurance. And we know that Medicaid is only paying 60 or 70% of the cost of providing the care. And it's the commercial insurer we're essentially paying 150, 175, or 200% of cost, right, to cross-subsidize the underpayment by federal programs, Medicare and Medicaid. So if you have a disproportionate share of patients with Medicaid in a socially vulnerable community, because of the financial incentive doesn't exist because that payer is paying less than cost, it's going to be pretty hard to attract providers there, right? Because they can't cover their costs. So, as we talked about earlier, we have to look at this more systemically if we're going to solve these problems. We're going to be able to identify in our atlas where we have poor health outcomes, where we have disparities, where there are fewer providers. But then we're going to have to say, what is there about the incentives that exist that would attract providers to address those disparities? Or are we just going to try and regulate it into existence? Even if we force providers into those communities, if the payment structure is such they can't cover their costs, are they going to be able to sustain that over time? And there was a recent forum where we were looking at the drivers of healthcare costs in Connecticut, and we talked about this as something that we all have to face. We can't keep ignoring the fact that Medicaid payments aren't covering costs, and therefore commercial payments are inflated because somebody is paying that cost. Currently, it's employers and increasingly consumers, because employers can't afford those rising premiums and are pushing more of the cost to consumers in form of premium share, copays, and deductibles. So again, this is an opportunity for us to really take a serious look at how care is being delivered in this state from a systemic standpoint, and what those incentives are. And it's going to be uncomfortable, but if we're going to solve the problem, we have to do that.
Let me just add to Pat's comment as well. In some cases, when we're talking about healthcare deserts, we're talking about communities that are less than 50,000 people. And the request is, and we understand traditionally and historically those services have been there, but they're asking to keep services with a declining population, same level, same type of services as if they were communities of 250,000 people. And so in terms of incentives, at a certain point, there's just not enough incentives to make it viable and sustainable in those communities. So there are some brutal realities that we all need to confront. There's a reason why there's been a lot of closures across the United States in terms of hospitals, actually more so in the most recent half decade than all of the last several decades. And so there are some brutal realities that I think we, Connecticut, have to confront here as well.
I just wanted to follow up on that comment. If if that's the case, why are large systems buying smaller hospitals?
So it depends. In terms of certain areas, there's a balance of criteria that they're looking at. Obviously, if certain hospitals are in areas that they're looking to grow, they represent physician groups that are very loyal and are valuable to extend that particular health system. So there's a whole variety of criteria that health systems are looking at. So it would be dependent on the particular situation.
Yeah, it's interesting that, you know, a larger system would buy a smaller, you know, hospital in a lower population area and then talk about closing services. So I think that's a discussion that we will continue to have, you know, as well. Like, what is the driver for that? And then Patrick, I just wanted to comment on that cost driver forum. I believe it was OHS, and OHS, please feel free to chime in here, said that raising Medicare and Medicaid reimbursement was not the answer.
Yeah, Representative, you had one speaker there who said that, and he cited he cited a particular article or articles written by a particular author, and then when pushed, he said, well, that was more hypothetical. He was saying, well, I was talking about the cost shift, the fact that because we have federal government paying through the Medicare program about 90% of costs and Medicaid paying between 60 and 70, that commercial rates were inflated. They were actually paying more than cost. He said that cost shift doesn't exist. And then when pushed, he kind of backed off. It's well accepted that phenomenon exists. The healthcare delivery system in the US is based on a system of cross subsidies. And it's worked while somebody was willing to pay at the commercial level, right? As long as the employer was willing to pay the premium to pick up that shortfall from the governmental payers, it all worked. But as employers have said, we can no longer afford this and be competitive because healthcare costs are such a large part of our operating costs, we can't be competitive with our foreign competitors. They pushed more of the cost onto employees. The average employee in Connecticut that has employer-provided health insurance is paying 30% of the premium in terms of payroll deduction, and then has a $3,000 deductible and copays. Now the employee is saying, Mr. Employer, I can't afford this anymore. And so now the employer is saying, we're not willing to subsidize, and it's all falling apart. We can't continue to do this. So that was what I was trying to point out. His rebuttal was that cost shift doesn't exist, but then he kind of crumbled. It does exist.
Yeah, and I'd also love to see the numbers over the last, 40 years, the number of commercial plans and the number of government plans. Like, are we increasing the, are we shifting more people to Medicare and Medicaid, which is putting more pressure on the commercial market? I would guess yes, but I'd love to see those numbers.
Well, the demographics of Connecticut speak to that, right? Because the working age population in Connecticut is shrinking. So, if that's true and we have the population that's aging in Connecticut, a higher proportion of the population in Connecticut is going to be on Medicare that doesn't pay the full cost. So there's a smaller population to shift to, right? And in terms of the youth population, a higher percentage of the youth population in Connecticut is on Medicaid. So you do see a higher government payment. If you look at the payer mix in Connecticut, it is deteriorating, meaning there's less commercial and there is more governmental pay. And then we have this issue of Medicare Advantage, who's taking the Medicare program and commercializing it. And you would think, okay, that's good because they'll pay more. They're actually not, because they're extracting profit out of the Medicare program that was only paying 90% to begin with. So now 56% of Medicare enrollees in Connecticut are in Medicare Advantage, and you have the commercial players taking a piece of that pie. There's less being spent on care delivery. Now, again, this is a question of a systemic issue that's leading to some of the problems that we're identifying today. So again, that's what we were trying to get into the cost driver forum. I don't think we can solve it today, but I think it's certainly worth looking at.
Yeah, and there's a cost driver forum coming up on the 3rd, so let's make sure we have some diversity in those views on there. Off a little bit off topic here, but thank you.
Representative Wood,
Well,
this is Olga Arma from the.
Do we have anyone with their hand raised? I can hear someone talking. Who would like to speak?
That would be me. Oops, that would be
Olga,
me.
I can see you.
Yeah, okay, sorry about that. I was trying to look for the right reaction, but I couldn't get it. I'm sorry about that. I just wanted to make a comment about what Mr. Shamel said. I think some other areas also were raised at the forum. One of it was hospital efficiency. I mean, we're talking about costs, everything covering costs, everything at cost, but then cost includes every expense. Nothing is excluded, and you see variation in prices among the hospitals for the same service. You see for newborns, one hospital charging over $8,000, another hospital charging about $3,000 for the same service. So where is efficiency in the equation? Why do you have price variation as well? And then another area that was raised is market power. It's not just Medicaid underpayments. There's also market power, because one of the things that the NASHP analysis found was that hospitals that had fewer Medicaid patients had the higher commercial rates. You would expect that hospitals that had more Medicaid patients will have higher commercial rates, but we're not seeing that. We're seeing that it is market power, where the hospitals that have lower rates of percentages of Medicaid patients have the higher commercial rates. So we can't say that they're using, or because of the cost shifts, they need higher commercial rates to cover the Medicaid underpayments.
Let me just respond to that quickly. I think it's true. I mean, one of the things that was talked about the forum with consolidation gives larger healthcare organizations leverage with commercial players. This is about negotiation with commercial payers. We pointed out that from high to low, the lowest negotiated rates for the same service compared to the highest are 2.5 times the lowest. And again, it may not be related directly to, well, one population is serving more government pay, and therefore they need more commercial payment. That's certainly part of it, but then you layer on the fact that through consolidation, it's given some players more leverage in those negotiations. I happen to represent an independent hospital, and we're down toward the bottom of that commercial payment rate. Our competitors get paid twice as much. That's partly because of the leverage they have. If I said I want to get paid as much as the largest systems in the state, that wouldn't be well received by the commercial payers, because they don't feel we're that essential. So again, that's another factor that needs to be taken into account, but that doesn't eliminate the fact that if you have a high Medicaid population and those payers are not, the Medicaid as a payer is only paying a percentage of the actual cost, it's not going to attract providers to deliver service in a community where that prevalence of that payer exists, which was the representative's original premise. How can we attract providers into those underserved, socially vulnerable communities?
Thank you, Patrick. Representative Pavlak-Tomato.
I was just wondering if and I appreciate the discussion today and everybody's hard work. Was she asking about why there's a variation in the cost of services or the reimbursement rates by insurance companies for certain things? I just wanted to clarify.
I believe she was saying that there were different pricing for the same service. And
I mean,
but I'll let Olga clarify.
Olga?
Yeah, I believe that's what she was saying.
So I was talking about both in a way, because Mr. Shamel was talking about the fact that there's Medicaid underpayments, and I'm saying that when there's variation in prices as well, you don't only focus on Medicaid underpayments, because there is variation in price, which sometimes is because of inefficiencies among the hospitals. So that's what I was saying.
Okay. I mean, I know we've had bills in the past and we've looked into this, but I mean, so it's what the hospital or the provider is charging is your question about why there's variation. I mean, hospitals in different towns, and this is from testimony, you know, they pay different property taxes. They have, one might have bought a new piece of equipment, another one, you know, they have different salaries, and all these contribute, I mean, to why, you know, they would charge. I mean, they have a surgeon, you know, we have different surgeons at our hospital. You know, some have higher salaries than others. And, you know, some, you know, when you have different employees that want, you know, in order to keep them, you have to pay them more, you know, that varies from place to place. So, I mean, the concept of allowing the free market, which, you know, is what this country is based on, to be able to charge what, you know, to cover their costs is just something we've addressed in the past, and we keep coming back to it. But you know, until other costs go down, you can't expect the cost of their, you know, what they charge to go down. And it seems like a lot of times in this committee, that's what we are expecting. While the rest of the entire world and state costs are going up, people want to pay less, and that's just not the way it works. So, but I appreciate everyone's, again, everybody's input. It's been very helpful. So thank you.
Thank you, Senator Lesser.
Yes, thank you, Madam Chair. You know, I've looked at a lot of the literature to see if what we can justify in terms of understanding this idea that private payers are overpaying as part of the of a cost shift, and I don't find the literature particularly compelling. But obviously, there are huge variations in between hospital systems and hospitals. In the earlier cost driver forum, we did hear some discussion from some of the smaller, from one smaller hospital in Connecticut about giving OHS rate setting authority. And I was wondering if that was something that the subcommittee had looked at.
This task force didn't have that question.
Yeah, I don't believe that was part of, if you're looking at the report, yeah, it doesn't have that in there as points 1 through 10. But we can certainly, you know, convene, you know, a working group or, you know, a task force to study that.
Great, thank you.
Thank you, Senator. Dan Keenan.
Thank you, Madam Chair. And I just want to follow up on Pat Sharmel's comments regarding the relationship between commercial payments and government payments. And I do think there's been many studies that have highlighted the role of commercial payments in offsetting losses associated with government programs such as Medicaid and Medicare, and then also the relationship between kind of higher commercial payments associated with lower government payments within your payment streams that a hospital has. So a hospital that has a higher percentage of Medicaid is in most instances going to have a lower percentage of commercial payments in its revenue streams, is going to have less leverage in negotiating with those commercial payers, and therefore is going to be, in some respects, doubly disadvantaged by lower commercial payments relative to other providers, and also in some respects burdened with the underpayment that exists in the Medicaid program. And I will contrast that with kind of the general framework for public education, where you would generally think that communities that have less ability to support public education through their own property taxes will get more state support, so more funding through government and that government entity to support the education in those communities. I do think that's a very important factor that needs to be highlighted, and I just want to support that point. So thank you.
Thank you.
So, Representative Wood, we have one more question. I would just like to mention rural anomaly. So a lot of what's been talked about, I think, ignores the national rural experience. So when you talked about a lot of hospitals closing, a lot of rural hospitals closing, one of the major factors of that is it happened in all the states that did not expand Medicaid. Because again, with the lower populations, they're also not having huge numbers of people insured. They tend to be sicker, have more people who are eligible for Medicaid, less people employed by big companies in these rural communities. So a lot of people like to use the rural experience nationwide of those rural hospitals closing, but one of the biggest drivers of that has been the lack of Medicaid expansion. And a lot of those hospitals did receive or were critical access hospitals, which meant that they did get larger amounts of money from the federal government to be able to provide services. So Connecticut's unique. We've expanded Medicaid, and so it's not, the story isn't exactly translatable to the state of Connecticut from the national experience, but I've noticed people use on both sides use that that example, and it's a little bit more unique in Connecticut. But we had one more question, so that we needed to address. Equally a big topic. This group had all the big topics, I think, and this was on OHS requiring the ongoing investment into community needs, i.e. community benefit programs. And so once again, the consensus was really about, and this is a theme through the whole thing, that state needs to be more transparent and provide guidelines and definitions about community benefits. As the federal guidelines are very vague, to say the least. So if the state has an interest in it, then the state needs to be much more clear and transparent and to all parties. And there was consensus on that. There was consensus that really that the hospitals do serve communities, that they want to serve communities, and as they're major anchor institutions for a lot of communities, and they're nonprofits, and so they need to demonstrate that they are their positive investment in the community in order to justify their tax exemption. So there was agreement on these sort of general principles. The clarity would help a lot. Where there was less agreement was what exactly should it be? Should it be regulated? And so what we did was put some questions here about how some questions that we had about it. So there is an organization called the Lown Institute, which has, and we recommend everybody to take a look at that, has strictly made this a numbers game. They've taken all the tax exemptions and put them in one bucket, and they look at what the hospitals report as community benefits that they've spent in the community, and see where they are, and they rate them, and they rate them in a couple of other different ways also. So it's a really interesting website, I think, that at least would give a starting point for legislators to see what how they're thinking. But as we mentioned already in this last longer dialogue, there are hospitals that are very small that don't have a lot of endowments. There's hospitals that that do a lot but don't know how to capture it, because again, they don't really know that they can capture it. There may be a smaller hospital that participates more completely in the community with local representation, but doesn't actually count the time or the hours, or they're not giving guidance on that. So how do we create a system for capturing what hospitals would include in that, and is some of that more qualitative than quantitative? We've had all these discussions. So there was a pretty strong contingent that it shouldn't be like a number percentage, and then there were others that think that would be helpful because that would be more clear. We are recommending, though, that as a step, now that OHS is already looking at the community needs assessments, that we strengthen their oversight and authority over these needs assessments, and that tying some of these implementation plan activities should be included. And I think the hospitals will actually do that into their community benefit report that they have. The topic, I think Jean talked about it earlier, that, you know, if the state really does have the goal of containing costs and addressing health equity across the state, that maybe other organizations that that don't primarily serve Medicaid and underserved populations, other private healthcare organizations, maybe should be included in some of their some of the work about giving back to the community. So I really went over that very briefly. So if there's anyone on the community that really wants to talk to this, I'd appreciate it. But it was a big topic.
It is a big topic. It is very fascinating topic. I feel like I have 100 questions, but I thought maybe, and I hate to put OHS on the spot, but I thought maybe if OHS wanted to chime in on some of this, because, you know, like the questions that you proposed, Nancy, like how do we create this system? And what is OHS already doing? I mean, maybe they're already working in this space. I'd love to kind of get some feedback from the OHS team on this.
Thank you, Representative Wood, for that. I know Laura and Steve both have plenty to contribute.
Good morning. Yes, thank you. Thank you, Kim and Steve. I will leave you space to answer too, but we have another staff person at OHS whose focus mainly seems to be, I think, community benefits and community benefits investment. And we were successful last year in the legislative session passing a community benefits bill that would require some additional reporting of the community benefits that are, as Mr. Sharmell pointed out, required for nonprofit hospitals to retain their nonprofit status under the Internal Revenue Code. So yes, so as of the end of 2022 calendar year, hospitals are supposed to report in their community benefits, and we are gathering them and taking a look at them. Community benefits itself is a very complicated component of the federal tax code, and there are no existing federal documents that make it easier for us or easier for the hospitals to compare one hospital to another. We are trying to minimize the additional burdens that we are putting on the hospitals, because we just really wanted them to share something that they've already produced. And so sometimes that comes in a PDF form and shows what their community investments are or their community benefits are. But there are no real standards based from the federal level that we can really say these are apples to apples comparisons. And we would obviously like there to be that level of a baseline of understanding if we are going to be able to make some rational or appropriate suggestions for tracking or for investment. So we are really, once again, we're at the outset of what we can do with this data and what the hospitals, how the hospitals track their contributions. Steve, do you have anything else on community benefits?
Sure. I think as far as community benefits goes, we also have been using it to sort of bridge when it comes to compliance. Many of the when you see change of ownerships and certain significant CONs, that is something that we've been working with the hospitals to sort of go beyond what they currently are offering and perhaps tie it to this community needs health assessments. And many of the hospitals have been sort of stepping up and sort of putting services where they've been certain monies where it's been needed. We've also been tracking that in our compliance by having special spreadsheets that we've developed. We've also that sort of track how much money was spent on each benefit that was provided to the community, even down, for example, if it's smoking cessation or something like that, everything is documented, including education that goes into the community. We have been trying to work closely to also develop a closer relationship when it comes to compliance. Many of the hospitals have asked that we work with them to include other things, other services that they've been offering in the community that goes beyond the definition of the IRS. And we are doing that. We will be including that in our compliance. So we do gather quite a bit of that information. However, like Laura pointed out, there is no, other than what the actual definition of community benefits is, we don't have anything else beyond that. So we've been using the CHNAs or the community needs assessment to put services in the community where they're required. And we're trying to do it more with each CON that comes in. We've also been trying to work and sometimes we've negotiated settlements with not just the hospital, but also with other providers such as an outpatient surgical facility or a physician group practice that may be saying, okay, they're going to increase their access to Medicaid, or they're going to increase certain services, or even for behavioral health, offering certain beds or scholarships in the community for the people that are needed. But like Laura, going back to what Laura said, there is no definition. And I know some states, they have percentages or they have some amount that's put together towards as part of a CON that comes in. We do not have that, but I think we've done the best we can with what we have in hands, working with the providers and trying to put the focus back on the community itself.
Excellent. Any other comments? Any final questions for the task force? Okay, well, I thought this was a really interesting discussion. Thank you everyone for your hard work. I know it was a lot of time and not always easy, but we have been slowly working on CON issues starting last session, and we'll certainly raise the concept in our committee going forward. And this task force report will be posted on the Insurance and Real Estate Committee's website, along with a review of this informational forum. And we'll continue the discussion and work with everyone on this call and others to keep trying to make some positive changes for everyone in Connecticut. There are no other comments or questions. We will close the informational forum. Thank you, everyone.
Thank you.